Hi, my name is Gail Houseman. I'm a nurse with the ALS Association, and I'm here to talk about invasive mechanical ventilation and some of the nursing and other considerations related to this choice. So the differences between ventilation, there's non-invasive and invasive. Non-invasive involves a mask or some sort of mask over the nose or the nose and mouth, which is connected to a machine that helps the respiratory muscles. Those machines are called, some people are on BiPAP, other people are on Trilogy, other people are on something called a Voxen. And these machines provide inspiratory pressure, so pressure when you're taking a breath in, and they help the respiratory muscles to take a better breath in. Initially, these machines are often used just at nighttime, and the goal is to support inhalation. Hopefully, with this type of machine, you're going to feel a little more energy because you don't have to work as hard to breathe. And some people use these machines 24/7. Okay, like it might start out as at night, and then you start using it more and more. Invasive mechanical ventilation, the difference is it involves a ventilator, a machine that does all of the work for the respiratory muscles. So the ventilator is hooked up to a surgical hole in the throat called a trachea. And from there, the machine does all of the work of the diaphragm. So it takes over the breathing. If you choose this option, it requires a 24/7 awake caregiver. And that's mostly because people need to be suctioned that have this type of device. I have heard on occasion that there's some caregivers have told me that their loved one is fine at night and doesn't need to be suctioned. And so, there is some variability to this. I just wanted to, so I've been with the chapter for 21 years now, and I just wanted to relay my experience with invasive mechanical ventilation. The very first person I ever heard from 21 years ago, I got a phone call, and it was from a mom, an elderly mom, and she told me that her, I'm going to guess he was in his 30s, year-old son, was invasively ventilated, and that he was coming back to their house to live. Two elderly caregivers. The mom told me that she had some training, but not that much, and that as far as she knew, there was no home care arranged. Nobody to come to the home like a nurse to teach them to make sure that they're okay taking care of their son. And the mom's question to me is, what do we do? My second experience was I was asked to see a patient in a nursing home, a skilled care facility that took care of people on ventilators. And I'm going to guess she was in her 60s. She was unable to communicate. There was no visible independent movement. It looked like she was not able to blink or move her eyes for yes or no. When people are paralyzed due to ALS, a lot of times their eye movements, they're able to move their eyes back and forth. And so, you move your eyes to the right for yes, you move your eyes to the left for no. I couldn't get her to do that. And the really frustrating part for her and me was that she looked like she wanted to communicate. She looked kind of almost panicky, wanting to communicate. Her husband was there. He said that his wife had developed respiratory distress. He called 911. She was intubated on the spot, and then eventually transferred to a skilled care facility. And the husband had told me that there was no advanced care planning prior to the 911 call. So challenging situations, both of them, and what I've learned over the years from those experiences and others is that there's really a need for people to be educated about their choices. and whatever they choose, what that would mean as far as care going forward. My sense is that education should start early on, prior to having any kind of an emergent event. I mean, I know you can't always say when somebody's going to go into an emergency, but usually there's signs and symptoms that people have prior to going into respiratory distress. Another thing that I learned is that you have to have enough people to care for people. So 2 elderly people caring for a 30-something-year-old son is probably not enough. And that skilled home care needs to be arranged prior to the person being discharged. So all hospitals, all facilities have people that arrange home care and equipment so that there's a smooth transition, hopefully, from the facility to home. And if the person has, a ventilator, then certainly all care should be arranged prior to, which would include an RN and hopefully a home health aide to help with the bathing. And in addition, also a respiratory therapist to come out as soon as the person's discharged. Skilled care is usually covered for a period of time by the person's health insurance. It's rarely beyond a month, but usually you can get at least a month of people that'll teach the caregivers how to take care of the person. Another thing that I've learned, especially this one over the years, is that advanced care planning should begin shortly after diagnosis and should include disease progression. One of the really challenging issues with ALS is that the disease continues to progress, and that would include the breathing muscles and also communication. So we're hoping that people talk about their healthcare wishes with their families and their healthcare teams, and that this is an ongoing presentation. And that also that communication be addressed prior to. So some folks with ALS, it might start with the muscles that they use to speak. And so, what happens with those folks is that it's best to, however they are able to speak or communicate, whether it's through an iPad or a phone or a fancy computer or a board, that they communicate what it is that they want. Suggestions. Again, communication. Talk to your healthcare folks, talk to your families, meet as a family, include children if children are in the home. Children are they're going to be curious. They're going to know that something's up, and they need to be part of the discussion. For folks that decide to go with invasive mechanical ventilation, my suggestion is to communicate how long you want to be on the ventilator. I'm sure that's not an easy conversation, but so some people on invasive mechanical ventilation say, I want to stay on the ventilator at all costs. I don't ever want to come off. Other people say, I want to come off the ventilator if I reach a certain point, and they would identify what that point is. Quality of life, lack of communication, whatever. I mean, people have different reasons to go on a ventilator. Some people want to see, a wedding or a graduation or something. They want to be around for so long, and then they say, and then I'm done. Other people say, no, I want to keep going. The important part there, though, is to communicate. Look into care. For instance, who's going to provide the care, the financial end of care, the availability of care prior to the need for invasive mechanical ventilation. As Anne and Melissa are going to talk about in their presentation, they're two of our social workers. There's some places in our area that it's hard to find care. It's especially been hard to find care with the COVID. And then you want to look at your home. Is my home accessible? What do I need to do to make it accessible? Should I move? Those kinds of things. And then look into transportation. So for instance, somebody who has a ventilator is probably going to be in a power wheelchair. And a power wheelchair is not something that you can just put in like the trunk of a van or a car. You have to have that van transportation for that. So you can speak to your social workers about that, about purchasing a van, renting a van, and finding other resources for transportation. So potential positives of being on a ventilator, the biggest, I think, is that you'll most likely live longer. I mean, a lot of people with ALS, they're it's an average 2 to 5 years after diagnosis. There's plenty of people that live beyond that, but if you choose invasive mechanical ventilation, your chances of living longer are much higher. You could live for years on a ventilator. Again, you might want to stay alive long enough to see, a special event, like, a wedding or the birth of a grandchild. You might feel as if your quality of life is good, or at least, decent. You might find that after getting everything set up, care, equipment, etc., that you have what they call a new normal with your daily living. And then, rarely, but occasionally, some people with ALS on invasive mechanical ventilation are still able to work and or be involved in activities or projects that are important to them. Potential negatives to being on a ventilator. If you look at the studies, some of the studies suggest that the quality of life for the caregiver, for the primary caregiver, is poorer than the person on the ventilator. So you have to consider your caregivers. There's financial concerns that the social workers will talk about: care, housing, transportation. Sometimes we find that there's discrepancies between what the person with ALS wants and what the caregiver wants. So we've had it where some people want to go on invasive mechanical ventilation, but their loved one doesn't want to take care of them and doesn't want them to come home, or the other way around, where the person doesn't want to go on the ventilator and the loved ones are really pushing him or her to do so. So that's why communication is so important. Another thing to consider is that ALS continues to progress despite the ventilator. So some people go on the ventilator and they're still able to maybe move their arms, maybe walk. Occasionally I hear about people on invasive mechanical ventilators that are still able to eat by mouth, which is rare, but there are some. And then, very sadly, and, eventually all of these voluntary muscles die, so the disease continues to progress. And then there's always the potential of not being able to communicate effectively. Elisa Brownlee, who's our assistive technologist, will be talking about that. So I started out with my experiences, and I'm going to end. So I'm 21 years later. What I found in my 21 years, and of course this is just my own opinion and it's a generalization, is that some people, including the people with ALS and the caregivers, seem to manage okay. Eventually, as long as they have what I have is their ducks in a row, and that means all of the equipment, caregivers, accessibility, communication, as long as they have everything set up. The people that choose not to go on invasive mechanical ventilation usually go on either a palliative care program or a hospice program. And they still continue to use their BiPAP, Trilogy, or Voxen for respiratory support. That some people qualify for skilled care in the home, either through their health insurance or the state waiver program, and the social workers will be talking about that. There's usually a period of adjustment for all. From generalization, it seems like it takes a little bit of time for everything to sort of come together, and that's normal. I think it's important to continue to assess the person's medical wishes. Persons on the invasive mechanical ventilator, do they want to continue? Is there a point where they want to come off of that? And I also think it's very important for caregivers to get respite time away, since their quality of life is impacted with the decision to care for somebody who is on a ventilator. Thanks for listening. If you have any questions about invasive mechanical ventilation, I would encourage you to speak to your physician and healthcare team, and feel free to contact me with any questions. My contact information, my phone number is 215-664-4134, and my email address is Gail, Gail, @alsphiladelphia.org.